Thank you. So our last speaker is Shari Barkin, who's been the leader of this workshop. So I want to add my thanks to her for that. Shari is the William K. Warren Family Foundation Chair in Medicine and is Professor of Pediatrics at the Monroe Carroll Jr. Children's Hospital at Vanderbilt University. Her laboratory studies family-based, community-centered clinical interventions to improve health behaviors such as physical activity and nutrition in parent and young child dyads. She will speak on the topic of theory to clinical practice. Shari?
So I've been given this really incredible task that in the next 15 to 20 minutes, I'd like to see how we can apply the science to clinical practice, given all the caveats that we've heard earlier today about being population-specific and context-specific. So if we know that what happens in utero and early in life, such as excess gestational weight gain and rapid infant weight gain in the first 6 months of life, places a child at higher risk for insulin resistance, hypertension, and obesity in later life, how do we apply this science to clinical practice? So this is my topic to review to you today, and I'm going to break this down by developmental period, consideration of potential application, and whenever possible, I'll highlight evidence if it exists. I also would like to present additional ideas that haven't yet been tested, but have been made clear that we should consider that. So this is, you'll notice my pregnant woman does have a head. I would like you to take off the ponytail and also see that as the father too. So we know from science that offspring exposed to both under and overnutrition in that maternal gestational period have similar metabolic dysfunction. And I really want to keep highlighting that. So when you hear obesity, I want you to also think that that's a marker for metabolic dysfunction, and that includes things like insulin and leptin resistance. Then it would make sense to set clear, balanced nutritional patterns early in life to maintain during pregnancy and reinforce it consistently in clinical settings prior to pregnancy and during pregnancy. So if I consider what was said about fathers, that means we are already in pediatricians' offices talking to boys and talking to boys about their nutrition. So I think that there's a direct correlation there. But I also think when we speak with women and other family members, we should do that in multiple settings. So pregnancy doesn't just belong in the OB's office clinically. We see plenty of pregnant women in multiple other settings. So maybe there are opportunities there. Also, it's very clear that regardless of whether you change your BMI or not, that exercise is beneficial for your health. And in childhood, we just call this play. But exercise during pregnancy can mitigate the development of these metabolic dysfunctions, regardless of whether you lose weight. So we need to be encouraging mild to moderate exercise daily and making these 30-minute recommendations. Now, I'm a very practical person. I'm the division chief of general pediatrics. We see 42,000 outpatient visits a year. We supervise and run our newborn nursery. It's about 5,000 births a year. And I can tell you when these recommendations meet actual application in the office. So nothing is as straightforward as why don't you exercise 30 minutes a day? In fact, I would like to give you all this challenge. I am now telling you, and you know scientifically, that that's probably that will offer you the greatest health benefit of anything that you might consider doing. So I'd like you to engage in 30 minutes of physical activity every day. So I've just conveyed knowledge to you. How likely is it to change your behavior? So I can tell you that most of our patients, it's not about knowledge. Knowledge is necessary but not sufficient. It's about skills and context. There have been hundreds and hundreds of pregnancy interventions, and they vary in approach. That might be a group versus an individualized session. They might vary because you get health calls, coaching sessions that might come from a trusted provider or someone who is part of an insurance plan that you've never met before. So just because you have the label of health coaching, for example, you have to understand how it's delivered. They also vary in dose, how many do you need, and timing, when is best. They vary in the outcome measures, and they vary in populations. So with all of that as a caveat, I wanted to highlight just a few pregnancy interventions. This is Chasen and Tabor et al., and this is called the B.A.B.Y study. This was 110 prenatal care visits, 60% of whom were Hispanic, the women that participated. They were randomized to a 12-week exercise intervention arm versus a health and wellness arm, and it was during the second trimester. Now, what they did was they matched the physical activity goal to your willingness to do it. Then the goal, of course, was to get to that 30 minutes of exercise every day, or at least 5 or more days. This was accomplished with one face-to-face visit and weekly mailed surveys and individually tailored reports, as well as 12 weekly telephone calls that were utilizing motivational interviewing. So raise your hand if you've heard of motivational interviewing. And so that's about 50% of you. And this notion of motivational interviewing is that I, as the expert, might not actually know your context. And so even though I'm conveying expertise and knowledge, if it doesn't meet with any agency, then we won't be able to change behavior. And this study took that into account. They measured outcomes with a pregnancy physical activity questionnaire, and what they saw was that the exercise arm experienced a smaller decrease in physical activity in second trimester compared to the control arm. So sometimes we're talking about how we get to more, and perhaps just getting to better can affect outcomes, especially if you see patterns of decreasing physical activity during pregnancy. Centering pregnancy has been around for quite a long time. This is a national model of group prenatal care. It applies adult learning theories that highlight the importance of group work and participatory process. You bring together groups of 8 to 12 pregnant women at similar gestational ages, and you meet 10 times over 6 months, facilitated by a nurse practitioner or midwife, usually the same one for continuity. You have 2-hour sessions and discussions, and it talks about many of the things we've discussed and some we haven't. So nutrition and activity absolutely are part of that. So is stress reduction, relationships, and parenting. And participation is defined as attending even one group session. So I want you to always ask this question: dose. What is the right dose that we need to consider? Now, with this, they've been able to show consistent reduction in preterm birth. And the question that we have is why? And were there any mediating pathways through the things we've been talking about? There are multiple ongoing evaluations. And so I am certain that in the next few years, you will see a flurry of these publications. But as a removed indicator, this is from a recent study related to centering parenting, where they looked at whether women even recalled having these discussions, and they compared it to typical prenatal education. And the main thing that I wanted to point out is that you can see that the appropriate amount of weight gain during pregnancy and exercise or active living during pregnancy, they were discussed in relatively equal amounts. So about 70 to 75% of these cases, they were talking about these topics and women recalled it. So if you can't remember, you can't lead to the next step, which is actual behavior change. What they were able to show that statistically was different in terms of recall was nutrition and cigarette smoking and secondhand smoking, as well as alcohol consumption. So stay tuned for more details. You can see that we are in the evolving stages of examining evidence related to this type of clinical application. The second part of pregnancy that I'd like to highlight is that we've been discussing that maternal excess gestational weight gain interacts with pre-pregnancy weight gain to alter early infant growth trajectories. So we should be setting clear goals for appropriate weight gain during pregnancy, and perhaps we should be utilizing group visits or phone call coachings during pregnancy and after pregnancy. But I think we should also really be concentrating on appropriate weight loss after pregnancy. That's a lever point. And that would mean linking to effective community weight loss programs. So you've heard quite a lot about excess gestational weight gain. This is from the Institute of Medicine's guidelines that were reconsidered and re-released in 2009. And we know that women who experience excess gestational weight gain have children with an increased risk of higher BMI and systolic blood pressure at age 3. But it's not merely the excess weight gain we have to consider. We have to understand how that's interacting with the pre-pregnancy weight, and we've heard about this before as well. So in a study conducted by Bill Hierman et al., this was from our work in Vanderbilt, what we noticed as we examined 500 women using a large database where we also have a biorepository, we wanted to understand gestational weight gain, and we connected maternal and child records, and objectively measured weight. So often in these studies, you have self-reported weight, and as you can imagine, that's less reliable than objectively assessed weight. And then we wanted to examine infant growth trajectories. And the main thing that I wanted to highlight here is that you can see in this red line overweight prior to pregnancy and excess gestational weight gain, and the resulting infant growth trajectory in the first year of life looks different than mothers who were obese prior to pregnancy and also had excess gestational weight gain. That's actually this top red line that's dotted here. And there was about a 13% difference at 3 months of age. The other thing that was interesting for us to note that we are in the process of replicating now to see how we can utilize this information and if this trajectory and shape is indeed true, is that there was a rapid increase in the first 2 months of life for infant weight gain, followed by a dip, and then it returned again and ended up a year later much higher than those women that also had excess gestational weight gain but were merely overweight prior to pregnancy. So I'd like to highlight this notion that we have an opportunity to focus on appropriate weight loss after pregnancy. That ideally, if we apply the science, would get us to a pre-pregnancy weight gain that would be healthier so that we wouldn't have this interaction that I just showed you, as well as creating that pro-inflammatory state that you heard discussed so well yesterday by Jed Friedman and many others. So raise your hand if you've heard of the POWER trial. And that is about 5% of you. The POWER trial was not actually intended for post-pregnancy weight loss, but it's evidence that shows what an effective weight loss program could look like. And perhaps we need to utilize this approach post-pregnancy. The POWER trial was 6 primary care practices in Baltimore, 415 obese patients. 41% of whom were African American. Not all of these participants were women, but the majority were. And they were randomized to 3 conditions. So either a self-directed weight loss control group, a remote support only, so that's a health call, a phone call, coaching call from Healthways, or an in-person support group, which had a combination of individual and group sessions, as well as health phone call coaching. Now, the thing that was really surprising to the investigators is that the result that 2 years later of receiving these interventions, those that participated who you can look to see who lost at least 5% of body weight, you can see that we had from these results very similar effect sizes and findings, clearly effective and quite similar. So different dose and duration, I'm about to show you that, but with similar outcomes. This is important as we're practically thinking about clinical application. So I just wanted to highlight on this slide that when we think about dose and duration, we also are thinking about timing for pregnancy. Here it would be post-pregnancy. So if we applied something like this, we might consider that we would need to have this type of dose and duration to achieve the effect size that I just showed you. So what they noted for phone call coaching and this remote arm is that there was a loading. In the first 6 months, there were 14 phone calls, whereas then there were 16 phone calls for the remaining 18 months. That you need to create, and I think about this as a loading dose for medication, to get yourself up to the ability to then maintain and decrease the amount of dose and touch points after that. Whereas what you can see in the in-person plus session, same phenomenon where there were many more sessions in the first 6 months. There were a mean of 6.5 group sessions in the first 6 months, whereas there was just one in the next 18 months. And there was a mean of 4 individual sessions in the first 6 months and one in the next 18 months. It's not that they intended for there only to be one. There were many, many more opportunities. But in terms of behavior and what these participants were willing to do, they were much more engaged in that early stage. And they still were engaged enough to be measured and participate, but much less later. I think that this is important as we're thinking about clinical applications. And then here, just a median number of 5 phone calls. So think about dose when we're talking about clinical application. So Bennett et al. Did work where they presented the powered trial results to providers. And they said, how do you want to use these results? Because my session is about clinical application and in the clinical setting. And here in focus groups, providers said, our role is to refer patients to effective programs and provide endorsement, to provide patient accountability, to cheerlead when things are going well, but to provide a limited role in weight management and instead use this long-term trusted relationship to make further connections in programs that can provide the right amount of dose for the right amount of time. I'm now moving to the next phase of development, and that's infancy. So we've heard the science of maternal poor nutrition during pregnancy with rapid infant catch-up growth, leading to offspring who have increased adiposity, hyperphagia, and hyperinsulinemia. So we want to be providing support that supports the recognition of infant appetite regulation. So that might look like training providers to discuss and recognize satiety cues consistently with parents. And we might want to think about changing the pediatric paradigm for catch-up growth. Perhaps we should be slowing down the velocity. We need much more science to know what would be safe in early infancy. So we need to reassess these expectations for early growth for providers and parents as we are building a robust science to understand what the right velocity should be. And as you heard Matt say, the unintended consequences. So when we only look at adiposity, we might be missing neurodevelopment. Although you heard from yesterday's scientific presentations that we know adiposity is associated with a pro-inflammatory state, which actually affects your neurodevelopment in a negative way. So what do we know in this area? I'd like to highlight the work that Rothman et al. Are doing with something called the Green Light Study. The Green Light Study is a health literate, health numerate intervention that we teach. We're in the intervention arm at Vanderbilt, and I'm a co-investigator on this study. We teach this to residents so that we begin at 2 months of age talking with families about how to recognize satiety and how to provide soothing strategies that don't only involve feeding. And you can see that from these materials, they're really easy to see. We show pictures to highlight how can you tell when your child is hungry and how can you tell when your child is full. And we start having these conversations early. So we've just wrapped up this trial. Analyses are underway. Stay tuned for how this actually affected these mediators that we've been talking about today of nutrition, as well as the outcome of how these children grew over time. But I can tell you from recent work that was published from this group is that a larger bottle for children tended to result in increased consumption. Now, this is not normal. For those of you who are not clinicians in the clinical setting regularly, infants and toddlers were the prime examples of individuals that regulate themselves. Infants and toddlers up to age 3, we used to say, and science supported, knew when they were full and they stopped eating. And they would throw the plate away and they would push it away, and you could not get them to eat more because they had such a strong thermostat for knowing that they were full. But we don't see that as much in the clinical setting. We see that infants and toddlers are behaving like adults. If we're full, but we want that extra piece of chocolate cake, we can find a way to eat it, right? That's our hedonic drive that is superseding our homeostatic regulation. And it appears that that's what's happening in infants and toddlers. They are now drinking to the end of the bottle rather than stopping when they're full. Now, this is work from Ian Paul, who's here today, et al., and his team also included Leanne Birch. And this is the slim time intervention. So how can we just slow that weight velocity down, even if it's just a little bit? And remember, I showed you yesterday that when we say rapid infant weight gain, just crossing 1 centile in the science is defined often as rapid infant weight gain. And here, what we mean by rapid infant weight gain is crossing multiple centiles. So in the slim time intervention, this included 2 nurse home visits. One was 2 to 3 weeks after birth, and the other was after the introduction of solids. The first intervention instructed parents on identifying hunger versus satiety cues and how to respond in soothing. And the second intervention taught parents about hunger and satiety cues and skills to handle infant rejection of healthy food through repeated exposures. 160 mother newborn dyads were randomized, and they created 4 treatment groups. So you would receive 0, one of those interventions or the other, or you could receive both. And they have reported that those dyads receiving both interventions had a lower weight for length percentile. Basically, they slowed the rate of infant growth, that weight velocity, versus those receiving just one of the interventions or no interventions. Now, how do we apply this to toddlers? So we know that toddlers typically had a very good self-regulation thermostat, and now we are no longer seeing that. We also know that they are really imitating the world around them. That includes how they're eating and how they're playing. So we need to be thinking about how we're supporting and reinforcing toddler self-regulation and setting normative habits in nutrition and physical activity. Now here I want to emphasize, and you heard Matt say that we need to really focus on the community and connect into the community, that part of the role of the clinical setting is to make these connections into community-based programs. But I also would encourage us to look at some emerging science that if you include families in those outcomes, not the outcome being just to improve the health of the child, but the outcome being to improve the health of the parent as well as the child, that we can create a much different type of dialogue and goal setting. And we can also consider utilizing social networks to reinforce healthy habits. So we know that social networks can spread things like smoking, all of the bad things. We've seen that it can spread obesity, where it looks almost like a contagion. The question is, could we use social networks to spread healthy habits, nutrition, physical activity, appropriate sleep? So I just wanted to highlight a little bit of the work that we've done in the past. This is called Salud con la Familia, Health with a Family. And our goal was to examine a family-based, community-centered intervention to prevent and treat obesity for Latino parent preschool child pairs. So as I mentioned, knowledge is necessary but not sufficient. This was a skills-building, dyadic intervention where we were focusing on improving the health for both the parent and the child and connecting them to use their built environment to reinforce those habits. What we found was that already 41% of Latino preschoolers were already overweight at the time of entry into the study. That's much higher than any of the CDC statistics that you see. We also saw that those who participated in the intervention group were twice as likely to change their weight category, so that if you were obese, you changed it to the overweight, and if you were overweight, you changed it to the normal in a 3-month period of time, whereas the control group continued to increase in their levels of overweight and obesity in merely 3 months. So the key things I wanted to highlight here is why. Why did we think that actually worked? It was very low cost. We followed Matt Gilman's recommendations, so we have cost effectiveness data, and we're looking at what is realistic when you find data such as these to say, when do you have enough to understand spread and dissemination? And we asked ourselves the question, why did it work? And one of the things we measured was social networks. So raise your hand if you've heard of social networks. Fabulous. That's about 2/3 of the audience. I'm not talking about social media, although social media could be utilized as a technology to get to improve social networks. These are bi-directional relationships. And what we know about social networks is that if you introduce new weak ties, that's how you introduce new behaviors, new knowledge. And that's what we were interested in measuring. So what we saw here is that the control group and the intervention group did start with some initial ties, and over 3 months, we actually built our intervention intentionally to build additional ties. So while both the control group and the intervention group did develop more ties over 3 months, the intervention group, it was much more significant and dense. So I need to wrap up, and I would like to say that the clinic setting is one of many environments that we should be utilizing to prevent childhood obesity. And we can consider doing that by perhaps changing our model. Maybe we should be providing more group visits and or linking to health coaching calls. We should be addressing nutrition, physical activity, for pregnant women in all settings and their male counterparts. So we should be including the father in these discussions. Now, it's not that any of the clinicians in this room do not want to talk to fathers. It's that it is much harder to get a father into the office setting. So we have to think about being practical when we think about these recommendations. We should consider linking to effective weight loss programs for postpartum weight loss to set up the next pregnancy. Addressing satiety versus hunger cues and soothing approaches during infancy starting early. We should reassess our recommendations for appropriate weight gain. Now, I don't mean we should go out and come up with a working group right now. We need clear science to guide us on what is the appropriate weight velocity in infancy. We should include families in setting nutrition and physical activity goals during toddlerhood and link to trusted, effective community programs. Thank you.